Welcome. I'm Thomas Thatcher, the manager of Intuitive Funding, and I'm happy to be your moderator tonight. We'd like to, first of all, thank all our sponsors, the Church of Jesus Christ of Latter-day Saints, the University of Utah College of Science, and Intuitive Funding. I also want to thank an excellent support team from the College of Science, Jeff Martin, Cassie Slattery, and Ann Vivian. They have been great to work with, and I really appreciate their help this week. We have got a wonderful panel tonight. First, former Governor Mike Leavitt. Mike, how are you? Thanks for coming.
You, Tom.
Dr. Joe Jarvis, epidemiologist and author of The Purple World, excellent book on the cost of healthcare. And then we have Professor Ryan Looper, a brilliant scientist and expert on vaccines, and Professor Fred Adler, who's a brilliant mathematician and data modeling expert. Just a couple of understandings. First of all, if you had a friend that did not get a chance to see this, this presentation will be available on YouTube. And so everyone who registered will be getting an email to that link so that you will be able to see it again. And we would ask that you would mute yourself and put yourself and stop your video. We're going to do that for you if you can't. And because you're not going to be able to be allowed to unmute yourself or take the video off. We'd like to go 90 minutes, and we're going to try to get through every single question that we can tonight. And so I would ask the panel to, obviously they need to answer the question, but if we could try to be as expeditious as possible so we can get to all the questions, that would be great. This is going to be a full 90 minutes as far as no breaks. And so if you do need to step out, you're sure welcome to come in and come out. Cassie will let you back in if you have to step out for something. Okay, so we'll get started. And I want to start with you, Governor Leavitt. The CDC urged Americans not to travel for Thanksgiving. And we talked about canceling Christmas. And now we talked about national lockdowns. New York State's locking down, Michigan's locking down, California's locking down. Then there's somebody who doesn't want to lock down, like South Dakota. I guess my question to you, Governor, is are we going for a lockdown and a national lockdown, and especially a lockdown as far as the state of Utah is concerned?
So this requires us to think a little bit about the structure of our government and who actually has the authority using public health law to require citizens to limit their activities. In our governmental scheme, we have the federal government, the state government, and local government. Public health is very squarely lodged in the state government, and they delegate various authorities to local government. So a lockdown in any of our state actually happens typically with the authority of the governor, and the governor may in fact delegate that to local government, and that's happened a couple of times. So the idea that we would have a national lockdown would only happen if the president or some other authority was sufficiently persuasive that they could get the governors in each of the states to use that authority. Now, obviously, there's a fair amount of disagreement, not just about lockdowns, but there's a difference of circumstance. In many states, in one state, it can be prevalence can be light, and another it can be catastrophic. And so applying the same medicine, if you will, to different situations really does provide a degree of manageability in this situation. And then it can switch. You could have the one that was light become heavy. And so again, having the local flexibility, there's virtue to that, and it is the nature of our system. I'll just say that I believe as prevalence continues to go up, we will see more activity on the part of government that'll look like lockdowns, but my guess is what we'll see are more surgical, what people are referring to as surgical lockdowns, where they're taking specific areas and beginning to limit activities in that area as opposed to doing it over the entire state.
Okay, thank you very much. Dr. Jarvis, thank you for being a part of this. I wanted to ask you about masks. Back in March, Dr. Fauci said it's not even a good idea to wear a mask because if you do wear a mask, you can contaminate yourself. And I was just thinking that if you had a mask on, I see people pull them down to eat or, to take relief from them or whatever. First of all, are masks effective? And second of all, if you're touching masks all the time, can you get COVID from that?
Well, without necessarily agreeing with you about what it was that Dr. Fauci said back in the spring, the short answer to the question is yes, masks are effective. For a demonstration of how effective they are, I ask all of the listeners to remember that we all know that physicians who are operating on patients in the surgical theater wear masks. They do that in order to prevent droplets that are created in the respiratory tract and exhaled with each breath, to prevent those droplets from getting into the surgical field and therefore contaminating it and causing the patient harm. They work very well. That's why antiseptic processes in the surgical theater and operating rooms, the antiseptic sort of procedures include everyone in the room wearing a mask. So yes, they're very effective. We've known this for many, many years, decades even.
Okay. But what about if you do touch your hands with the mask? Can you recontaminate yourself? I mean, is that a problem? Can COVID get on the mask, and then when your hands touch it, you can get COVID?
So let's assume for a moment that the mask wearer is actually infected at the moment that we're talking about, therefore contagious and exhaling particles that include the coronavirus, and those particles are hung up and contained in the mask material. That mask material is not a good substrate for the viability of the virus. It doesn't live long inside the mask. Surgical masks are intended to be disposable. So after a one-time use, say for several hours, they're intended to be thrown away and a new one applied. The answer is generally no. You're not going to be infected by a fomite, a non-living object that might get contaminated by someone touching it or coughing on it, because the virus doesn't live long in the environment. So that's the general answer. And specifically, if you're handling your mask correctly and paper mask being replaced as needed for new use, then you won't have any trouble being infected by using a mask properly.
All right. Thank you very much, Dr. Jarvis. Dr. Looper, we've heard some good news on the vaccine front lately. Can you tell me the difference between the front runner candidates, and are we going to be having a vaccine soon?
Sure, Tom. Thanks. I think as we've heard in the media, the cavalry's on its way. I think that's very much true. So right now, both Pfizer and Moderna have very promising vaccine candidates. They are new types of vaccines that are being launched for the first time. These are called mRNA vaccines, and they're proving to be very, very efficacious. So I think the numbers that we've seen coming out in preliminary data from phase 2 trials of kind of greater than 95% effective is pretty stunning for these types of vaccines. And like I said, this is the first time these types of vaccines have actually been deployed in the clinic. And so I think that's a lot of good news is on its way with the vaccine.
Okay, so just this quick. So if you're taking the vaccine, are you going to be able to only have to take it once? Are you probably going to have to get vaccinated twice a year? What does it look like?
Yeah, so right now both of the vaccines are requiring 2 doses for immunity. We don't know yet exactly how long they will last, but there's some smaller studies, right? So one big part of the problem right now is we don't have a lot of data from big studies because this virus is so new. But there are some shorter, smaller studies that are actually showing immunity lasting at least 6 months from this. And there's a lot of indications that this will actually be like the predecessor to this COVID virus, which was the original SARS outbreak, where we saw immunity up to 17 years in some patients. So while I don't think we should get our hopes up that we'll have 17 years of immunity, we have at least 6 months, and I would imagine that studies will show that the immunity will actually last significantly longer than that. So I wouldn't be at all surprised if we're in at least a, maybe once a year type vaccination scenario like the flu.
Okay, that's good news. Dr. Adler, how are you tonight?
Well, thank you.
That's great. We've heard about this R naught, and I understand that R naught, I guess, is a correlation factor. So if someone gets an R, if something is rated R naught of 1, then if a person gets sick, he will infect exactly one other person. Is that correct? Can you explain to us about R naught and all the media that's been going around on that?
Sure. Yeah, R naught is a beloved number for epidemiologists for good reason. It summarizes a lot of information in a single value. And so it stands for, like you said, the number of people on average that an infected person will infect. So if it's bigger than 1, if I infect 2 people, they'll infect 2 people. That's the chain reaction that leads to the exponential growth we don't want to see. If on average I infect less than 1 person, like sometimes an infected person will infect 0, sometimes 1, then the disease will die out by itself. So, and 1 is this critical number that we often see mentioned in the news. The naught in it, which is very British sounding, refers to saying that's the first infected person. How many will they infect? And that's 2 things change after the first infected person. One is, like Ryan just mentioned, people become immune. And so that lowers the number of targets you have. Second, like Governor Leavitt discussed, we change our behavior, whether it's individuals or the government. So then often we'll not talk about R naught, but RT or RE. But it's still the same idea. If on average I'm infecting more than 1 person, the epidemic will spread. If on average I'm infecting less than 1, the epidemic will die out.
Okay, great. Thank you very much. All right, well, now let's hear from all of the listeners here. We're very excited to get to their questions. So Cassie, if you'll throw the first question up here. If everyone wore masks and limited contact with others for just 1 month, what would the impact be and what would the things look like moving forward? So Dr. Jarvis, do you want to start with that?
Sure. And actually, if people, we had a natural experiment in a neighboring state that's something like this question. Arizona rose to a case count of 4,000 on a 7-day average per day in July. And then Governor Ducey introduced a number of measures which he intended to limit the spread, and that 4,000 per day case count dropped dramatically, and it was a sustained drop that now more recently they've seen a growth like virtually all states have in the case count per day. But if we were to limit exposure by wearing masks, therefore ourselves not spreading as many viral particles, and depending on the kind of mask, actually reducing the number that we might be exposed to through our own inhalation. For a month, we would see a dramatic drop in the new case count over that month. It's hard to predict exactly how much, but it would be more getting back to what we were like in maybe even the early summer from the state that we're in right now, which is over 3,000 new cases per day. And it would be sustained as long as we continue to behave in that way.
Okay. Anybody else want to weigh in on that question?
Yeah, maybe just to say in terms of this RT number, we have very good evidence that if everyone was careful and wore masks, we can get that below 1. That's why the numbers drop. And if you keep them below 1, that RT value, you keep dropping. So yeah, with fairly simple technology, we have the power to make this epidemic die away on its own.
And that's really the only thing we can do right now, right? When there's no vaccine. I mean, it's the best preventive measure we've got, correct?
There's
Correct.
some measures like lockdowns and so forth, but this one has the great virtue that it's up to us and it's much less invasive into our lives.
And so I think going back to the vaccine point and the idea that the cavalry's on its way, it's so critical that we take these simple measures to, what this question asks essentially is, can we flatten the curve? And the answer is yes, through these measures. And we need to do that until the vaccine gets here, because that's a simple thing to do and it's going to save so many lives if we can keep the numbers down until the vaccine gets here and we can get everybody vaccinated in the correct order and keep the community safe.
Okay, now
This might be,
go ahead, Governor. Go ahead.
This might be a good place to introduce a piece of language that I think we'll all use. Public health often uses a metaphor to describe how you defeat this kind of infectious disease. They refer to it as Swiss cheese. And the metaphor is simply that every piece of Swiss cheese has holes in it. And in order, so in order to, if you think about each piece of each type of measure we would take, masks, social distancing, limiting, all of those are a piece of Swiss cheese all put together. And if you do all of those things, the more slices you have, the more unlikely it is that a virus will get through all of those holes. And so the more of those things we're able to instigate, the safer we will be. So if we were to have a lockdown, if we were to, that would be that'd be perhaps many pieces of sliced Swiss cheese. But that's the problem, is that every time that's the objective. We have to add enough layers of defense that every one of them buys down, if you will, a little more risk.
Okay,
Great.
very good. All right, Cassie, let's go to the next question. What pre-existing conditions are affected by COVID-19? And what about the blood type? So Dr. Looper, we had a discussion about this too when we were talking about how blood types, some blood types like O negative may be less problems with the virus than other blood types. Let's talk first about the pre-existing conditions and then the blood type.
Yeah, so COVID-19 is largely it's a respiratory virus which causes a lot of inflammation. And so pre-existing conditions that are particularly pro-inflammatory or affected by inflammation are really affected by COVID-19. So especially things with the heart and the lungs, patients with pre-existing conditions that affect those organs are very adversely affected by this virus. So that's of critical concern. You get inflammation around the heart, you get inflammation in the lungs, and all of those things can be very detrimental. If your body's working hard to pump blood because of diabetes or because of high blood pressure, that's going to exacerbate those conditions. And did you have a question?
Well, is it safe to say then the digestive stuff is not affected then too much in your stomach or?
Not too much from what I've heard.
Okay. And then what about the blood type?
And then the blood type was this confounding thing that we became very entranced with early on in the pandemic, where there seemed to be some studies showing, as you said, that O negative blood types were less likely to be infected by the COVID disease. And those numbers, even at that point, were relatively small. I think in the single digit to teens kind of differential percentages of those patients getting infected. I was excited because I'm O negative, but it turns out that as we've gotten more and more data in, and Fred can speak to this, that difference has gone away. And so that's not surprising as we've taken stock of a much larger number of infected patients. And
so it's anything. Is it safe to say then that nobody's immune from this, that there's just nobody that can go out there and say, I'm just not going to get this? Is that pretty safe to say? I mean, we all are at risk. Is that correct?
Yes. Short answer, yes. Right.
Good.
So there,
Okay.
you
And
know,
I think that's important for people to realize that you are not immune from this.
correct. This is a completely new virus that infects host cells by a new mechanism. And short of you being some strange human being that doesn't have angiotensin converting enzyme, you're not going to get infected. But I don't know any of those individuals. So to the best of my knowledge, we are all susceptible to this virus.
All right. Thank you very much. Cassie, the next question. How can we counter the misinformation that surrounds this pandemic? Governor, do you want to try that?
Well, I think likely the best way and the only way is to just make sure there's more reliable information and that people know which sources are reliable. This is one of the reasons that the CDC has been important. The reason that public health sources is so important, that the website of hospital systems and that the news media is very carefully curating the sources that they use.
Okay. Dr. Jarvis, do you want to weigh in?
Yes, I think that we elect people to be our leaders, just just to deal with these kinds of emergencies. I mean, obviously they have other functions, but in the moment of our greatest need, we should be able to look to our political leaders who we know because they're out there in front of us and expect them to use the political capital that they have to do the heavy lifting of explaining what is going on with the pandemic, what the correct information is, model the right behaviors for us, and keep insisting on it no matter what it costs them politically. And I say that with emphasis because I believe that in this particular circumstance in the United States, we have not been served well by many of those who we've elected.
Okay. All right.
I'll just add, during,
go ahead, Governor.
yeah,
Go ahead.
Tom, I was just going to say that during a previous phase of my life when I was serving as the Secretary of Health in DC, we were actually doing pandemic preparation at that point because of a different virus. We spent a lot of taxpayer money trying to figure out this question. And the first thing we came to know was that people wanted information from public health professionals and from doctors. They do not appreciate, value, or for that matter, believe information they get from people who have a political motive, and they see through that. And I think that's a lesson that should be taken away from, we should be taking away from this situation, is that the way information has been conveyed, we know better how to do that.
Okay, now I might get myself in trouble with this, but I'll try it anyway. Do you think then that the resistance to like wearing masks or doing these protective things is part of the misinformation? Are those related in any way, or am I not correct?
Well, I think there are a couple of things at play here. One is that people do have different points of view on these things, and people have different level of risk tolerance. And science is not always aligned. You made the point earlier that we've gone through some iterations, and we can only go with the best available information. And sometimes that best available information changes, and points of view in science change.
Right.
That's happened here. But a rule I think we in the future abide by is that people do want to get information from reliable sources, and we need to make sure that they're able to speak freely.
Okay. Thank you very much. Cassie, next question, please. Did Medicaid expansion in Utah come at the opportune moment to battle COVID-19, or is it a hindrance? Dr. Jarvis, do you want to try that one?
Well, any kind of expansion of financing for healthcare is useful in supporting patients at the time of illness, pandemic or not. So yes, I think it was opportune that Utah, among a number of other states, expanded those who were allowed to take advantage of Medicaid benefits. So no, I don't think it's a hindrance. I think it's a help, as would any kind of financing for appropriate healthcare. One of the problems in the United States healthcare system is that people go uninsured or underinsured and therefore worry first about the finances around, for instance, getting a test, when in fact, from the public health perspective, everyone who should get a test, regardless of what it costs, should be supported in that. That is so important in trying to manage a pandemic. So I'm glad for the expansion. I wish we had more.
Okay, great. Anybody else want to weigh in? Okay, we'll move on. Next question. How can community and faith-based charities best help those on the front lines of COVID-19? Who would like to take that question?
I bet Dr. Jarvis could think that one through for us.
Dr. Jarvis, you're elected. Go ahead.
Okay. Well, there are charitable organizations that are clearly oriented to the care of the sick and or the injured, that support in the nonprofit approach to healthcare delivery. In fact, Utah's largest healthcare systems, the University of Utah and Intermountain Healthcare, are nonprofits and therefore, in a sense, charities. And they are obviously a great resource in helping us deal with this kind of a problem. So they, of course, need to orient themselves to the new and different problems that present themselves when vast numbers of people, far more than is usually the case, are ill enough to need to be hospitalized. Other organizations that support healthcare, that donate, probably could go to their donors and try to raise more funds. That may actually be important at some time in the very near future as we deal with what is becoming a very critical moment in Utah history, where our health resources are so stretched that we may not have a place for the next person who needs an ICU bed.
Yeah, that is definitely a problem.
And
two thoughts. Yeah, go ahead. Go ahead.
Sorry, I was just going to say, I also think of this going back to our previous question about misinformation. I mean, these types of groups have such trust within the community and such reach into the community that they're also a great place for helping us relay information about what we as individuals can do to help limit the spread of this virus. And so if we can, if those organizations can help us get the message out about these personal responsibilities that we can implement to, again, quote unquote, flatten the curve, that's going to help the frontline workers in this COVID pandemic by, again, helping our hospital resources go further and be less stressed.
Now, Ryan, while I have you on there, I was asking you about vaccines, and I don't mean to sidestep here, but I think this is pretty important. Those that might be, considering pregnancy or whatever, are there risks of those types of people taking the vaccine? Do they need to back off for a while before they take the vaccine, or are there people that should not take the vaccine that might have other medical problems?
Yeah, so as of right now, we don't know that data in terms of, these having undergone a incredibly large phase 3 trial. So we don't have those. I think it's not unwise for people with special circumstances, whether it's pregnancy, pre-existing conditions, to have that discussion with their medical doctors. As of right now, the inherent technology that's used in the vaccines does not appear to be toxic to any significant degree or cause any problems. There's a certain part of the vaccine, the carrier particles that encapsulate the mRNA of the vaccine, that have their own kind of profile. Those, as of right now, in these first clinical trials, shows no apparent significant toxicity either. So until we get the data, we can't answer that. But as of right now, it doesn't appear that these are particularly, let's say, wrong for any population that they might be given to.
So,
All
Tom,
right,
I'd be curious to hear Dr. Adler talk a little bit about the size of we keep talking about the data. How much experience, how much data do we need in order to begin to get reliability on these questions?
It depends on the question, of course. So for the vaccine, I think that the size of these trials probably is sufficient, given that they went out of their way to design them to capture a representative group of people. You can't get everybody. We're all unique in some ways. So I think we really do have the power to assess both the efficacy and the safety of the vaccines from those. The rest of the data we have is amazing in quantity, in terms of knowing who gets sick, when, and so forth. It would be great to have somewhat more data that was related to contact tracing so we could really understand how this virus gets around. But at the moment, at least I personally don't think we're severely data limited. I think we're in a very strong place to use the data effectively.
Dr. Adler, there's two questions I have there then. Are you really confident in the data we have as far as what is the projected death rate and how many cases we're going to have? I mean, some say the models are inaccurate, some say they're a little bit, too much blue sky. Are you feeling really confident in the models that are coming out that if we don't do things, we're going to have 400,000 deaths by the end of the year or something like that?
The models have been very accurate in terms of predicting things. And of course, there's many uncertainties. People have made the analogy, which I think is a good one, with predicting the weather. We're actually extraordinarily good at predicting the weather, even though people continue to have a myth that we're not. But the way the weather is predicted is through ensembles. That is, they run a whole bunch of different models and then look at the consensus among them. That gives us a certainty. If they're all singing the same tune, then we can be very confident. If there's a huge amount of disparity between them, then we're less confident. But overall, the models, which are extraordinarily simple from a mathematical viewpoint, have been remarkably accurate in making predictions. But there are certain assumptions in there to which they're very sensitive, and those are the ones we do have to focus on.
All right, so not to scare anybody, if we don't change our ways and fast, what are we looking at as far as possible death rates or whatever? Do you have any idea that you could share with us, or any data that you could share that?
Yeah, I don't want to quote exact numbers, but we are doubling roughly every 3 weeks, and doubling happens fast, right? So if we continue through the winter, doubling every 3 weeks, 6 weeks we're 4 times worse, 9 weeks or 8 times worse, and so forth. That's what the future looks like. And there are many responses to it. There's government responses, and there's also individual responses, which play a rather large role in controlling it. So we can't really predict what people are going to do. I think it will slow down somewhat, but at the moment, I personally am not that optimistic that it'll slow down to say where it was over the summer.
And Ryan, just because we get a vaccine doesn't mean it's going to slow down, right?
No, it's going to take some time to roll the vaccine out.
All right, let's go to the next question, Cassie. What is a realistic date for a widespread availability of the COVID-19 vaccine for seniors? And who will be vaccinated first with the small amount of vaccine they will have? So Dr. Looper and then Dr. Adler on those questions. Go ahead.
Sure. So my understanding is that this is already being planned to be rolled out within 24 hours of approval, which could come within the next 2 weeks. And if it's rolled out within 24 hours, my understanding is the first doses are going to frontline healthcare workers. And then I think shortly after that, the decisions will be made about how the vaccine is rolled out. But I would imagine that seniors are in that next 1 or 2 groups of people after kind of the frontline healthcare workers that are going to receive this vaccine.
And so Ryan, are you confident? I mean, if the vaccine was available in the next 2 weeks, and let's say you were one of the candidates to take it, would you take it?
Absolutely.
Okay. I think that's very important to understand, is that we don't have to worry it was rushed through or anything like that, that we're safe to take this. Is that correct? Okay.
Correct.
And then Dr. Adler, do you want to weigh in on this too?
No, I'll defer to Ryan on this one.
Yeah.
Okay.
But I'll go back to that point, Tom, because we do need to make sure that there's confidence in this vaccine, and the results and the efficacy we're seeing with this is outstanding. And let's say there is some risk associated with it. There always is with any medicine. You have to ask yourself, does the risk outweigh the benefit? And in this case, in this pandemic, I think we have to make the assumption that the benefit is significantly greater. And in order for this to have a significant effect within the community, we need to vaccinate as many people as possible, right? So we can have a discussion about why smallpox is gone and why polio is gone and why the flu's not gone. And we can talk about how that may have something to do with vaccination rates and so on and so forth. But the important thing is that we get that people vaccinated number up as high as possible.
Okay. And see, Dr. Jarvis, I'm a little bit worried too, because once we start getting the vaccine, then are we going to have people saying, yeah, we don't need masks anymore. Yeah, we don't really need social distancing. We got a vaccine now. Is that a risk?
Well, yes, obviously people don't wear masks as commonly as they should now, even without the vaccine deployed in the community. So I am concerned that the wrong message will be sent. We need to continue to do what we can to prevent spread of the disease until the rates are way back to background. And the vaccine will do that. It has the efficacy, assuming, as was just stated, assuming that enough people agree to be vaccinated, it has the efficacy to actually be a game changer for us.
Okay.
So Tom, I have a question for Dr. Jarvis.
Yes, go ahead.
Assume that we know the vaccines are headed to our state. They've been pre-allocated, and as soon as they are, they have been approved, they'll be distributed. And we know that, as has been said, they'll go to healthcare workers first, and then those who are medically fragile and in high-risk groups second. It's my understanding that it takes 2 doses, and that they have to be typically spaced 2 or 3 weeks apart, and that there's some time that elapses after a person has been fully vaccinated before they achieve an immune response. After all of those things have occurred, how would a person with a 95% effective vaccine, how would a person respond to that? Would they need to social distance? Would they need to wear a mask? Would they be exempt from some of the things that have limited them?
I think that we should, as a community, end up agreeing about the time that the masks come off. And I believe that it'll take us most of, probably all of the spring and on into the summer for enough vaccine to be distributed before people can begin talking about, easing off on some of these behavioral changes that we've been trying to get people to agree to and perform. As we see the rates of new cases drop, we can become increasing, and especially the rate of positivity on the test data, as it drops, and therefore we can see that the contagiousness is ebbing away, then we're ready to all together go back to something more like what we did before.
If we assume that,
go ahead. Go ahead.
If we assume that a person who has had COVID, tested positive, had symptoms, got through it, and then tested negative, do they need to wear a mask?
Yes, the recommendations currently are those who have had documented COVID should go back to, after they recover, should go back to the same behavioral changes that we're asking everyone to undertake, in part because there are small numbers of people who have had a second course or a second case diagnosed. In fact, there was one on Utah television just last night discussing, it was a labor and delivery nurse, if I remember correctly, who was for the second time suffering with COVID-19, in part for that reason, but in part to keep it simple and straightforward. Let's all be on this page. This is what we all need to do. And when we all don't need to do it anymore, then we'll let everyone know and we'll back off.
Now, let me just say something right here before you talk there, because you might have said this, but I wanted to make sure we're clear on this point. Once you get the vaccine, how long does it take before it works, so to speak?
Yeah, so that's what I was going to speak to in terms of we're having an initial vaccination, and then I believe it's 28 days later, so it's about 3 weeks or more until the second shot. And then it's thought about a week after that is when you have peak immunity. So if we think about, let's say we have 6 groups, we have doctors and nurses, we have the elderly, we have teachers, we have grocery store workers, we have, first responders, whatever. Let's say there are 6 groups of people we have to roll out this vaccination to. Each of those take a month to reach peak immunity. We need to keep all of us safe by these basic measures until all 6 of those groups are fully vaccinated and at peak immunity. And to Dr. Jarvis's point, the fact that we don't know if some of us still might, even if you've been infected, if you may be able to be an asymptomatic carrier after you're infected, or while you're being vaccinated or after you're being vaccinated. I think those are still questions in the community that we don't fully understand. And so we have to agree, as Dr. Jarvis said, to keep all of us safe until kind of the entire community has reached maximum benefit of any secondary measures that are launched against this virus, like a vaccine.
All right, Dr. Adler, did you want to say anything?
Yeah, just one thing, which is how remarkably effective these new vaccines are, say, compared to the influenza vaccine. One of the reasons people don't get it is it doesn't work that well, right? It's a 50% efficacy in many years. And what's surprising is that immunity to the flu is probably lifelong, but the influenza has this annoying habit of evolving really fast and replacing old varieties with new varieties every year or two. And that's what makes this race. One thing we don't know for this virus is how it will evolve in the future. It's actually evolved remarkably slowly throughout the last 8 months, from my perspective. I was quite surprised. And I'm hoping that somehow predicts the future and that it will, in fact, not evolve very quickly. Just as one example, measles is a virus that hardly evolves at all. That's why the vaccine works so well. It doesn't get around it. And so those are really the 2 elements that affect vaccine efficacy, or maybe 3. How long does it last? How much do the viruses run away? And how effective it is. And so with luck, we'll get all 3 of those, and then we'll be in this happy position to be peeling off the masks.
Okay, Governor, did you want to say something? I think I might have interrupted.
Well, I just wanted to call attention to what Dr. Looper said. You could take all of the healthcare workers and all of the teachers and all the grocery store workers and first responders and add all of them up, and you're still a relatively small percentage of the population. This is going to take some time, and we're going to have to continue to exercise specific social distancing behaviors and other types of behaviors for some time, at least through the next year, in my opinion.
Yeah, thank you. Okay, let's go to the next question, and I apologize for not moving a little faster. Should we continue to air out the house during the cold weather? Who wants to take that one?
I can take that. Yes, we should.
Okay.
I'll say that there's 2 reasons. One is ventilation, replaces the air more often. So if there's people in there who happen to be infected, the viruses that are often floating around in aerosols leave. The second is to deal with the humidity issue, right? As the virus strangely does worse at higher humidities. And so in the winter has been bad just because it gets so dry. And so it's keeping your house aerated and somewhat less dry will prevent.
So it's more humidity, not hot and cold, right? Because I know that the virus can still exist in a 80-degree, 90-degree climate, correct?
I don't know. Yeah, I don't know of any evidence that it's affected strongly by temperature. Maybe the other people do, but it's definitely.
Anybody else? Anything no temperature? Dr. Jarvis, do you want to weigh in?
Yeah, I'd add, I'd agree with the need for maintaining a good humidity, which is between 40 and 60% inside a building, partly because of how it affects the virus, but partly because of how it affects the human body's defense mechanisms. Humidity between 40 and 60% improves the function of the respiratory tract. It improves the mucus production, it improves the quality of the mucus, and improves the ciliated cells along the respiratory tract. These are hair-like extensions along those respiratory tract cells that beat in synchrony and move the mucus up the respiratory tract so it can be eliminated. Mucus is a very sticky substance, normally produced. It's a great defensive mechanism that captures the particles, including viral particles, as they are inhaled. And if the function is optimal of this whole protective mechanism, it brings those particles back up where they can be swallowed and go down into the gastrointestinal tract where they're harmlessly killed. Proper humidity is very important. In a climate like Utah's, where forced air heat, humidity is well below 40% commonly in homes, and we should use area humidifiers according to specification by the manufacturers. I emphasize that because you don't want it to become too humid. Above 60%, you induce mold growth, and that's another kind of respiratory particle that you don't want to end up encountering. But humidity is a very important part of maintaining a good quality indoor air environment.
All right, thank you. All right, let's move on. What nations or states have been most successful in combating COVID-19, and what can we learn from them? Governor, which the states are the best?
I don't think you can find a state in the United States that could be used as a good example.
Oh, wow.
None of us have done this well.
Oh, wow.
But the reality is we're all, the state lines are meaningless to viruses. And so what happens in one state has an impact in others because people are moving around. I do think you can look outside the United States and look at places like New Zealand. I mean, the key here is very simple. Do everything you can to keep it out so that it doesn't gain a foothold. When it is discovered, you move aggressively to do good contact tracing and to put people into quarantine who've been affected by it to contain it. A very good way to think about fighting infectious disease and pandemics in particular is the metaphor of a forest fire. We put observation stations in vast forests where forest rangers look for smoke. And when they see smoke, they dispatch full force to the side of the smoke because they know if they can contain that before it breaks into flame, they can keep the forest from burning. That's the same with the pandemic. Now, we're way beyond that now in the United States and way beyond it in most places in the world. That's the reason they call it a pandemic, is because it is a disease that's happening all over the world at the same time.
Okay, thank you. Let's move on. Next question. How much extra protection does one get from a surgical versus N95 versus a cloth mask? And anybody who wants to weigh in on that, Dr. Jarvis, so you probably have some.
N95 is a kind of mask that provides both kinds of protection, if you will. That is, it reduces the number of particles exhaled into the surrounding atmosphere, and it also reduces the number of particles inhaled into the person who's wearing the mask. So it is the standard, the gold standard of mask for use in this particular time, in this particular circumstance. That isn't to say that the other two varieties, the surgical and the cloth mask, are useless. In fact, there's clear data, and most of this is epidemiologic data, meaning it's observed data. People have actually found circumstances where, though sick, though having the infection and contagious, but wearing a mask, people like hairdressers haven't passed it on to their customers, or people who were ill who got on a plane and sat next to a variety of people or were in some other indoor setting but wore a mask did not pass it on. And that is true whether it's a surgical or a cloth or an N95 mask. So ideally we'd all have 5 masks, but early on in March, there was a limit on how many of those were available. I think that's still to some extent true. And we wanted to make sure that people who are on the front lines had access to the protective equipment that they needed. So we relied on these other kinds of masks in order to help everyone have some kind of protection.
Okay, so panel or Dr. Jarvis, if you were to rank them then, N95 is 1, would be the surgical number 2 or the cloth mask number 2?
I think most people would say surgical number 2 because that's made uniformly to certain specifications for use in the operating theater. Cloth masks are of a large different variety of things that are homemade and put together in a variety of ways, and some of them are less useful than others. So I put those, nonetheless, if that's what you have, wear it. But I put those number 3.
Okay. Anybody else want to weigh in on that? All right, let's go to the next question. How long is the immunity for someone who has recovered from the COVID-19 virus? Who would like to take that one?
So we had talked about that briefly before. So it's not, this isn't fully understood yet because we don't have large enough data on large enough population size that has looked at this fully. But again, these early studies are showing that not only in terms of antibodies, but also the B cells and T cells of the immune system that help produce the antibodies, these are still functioning and kicking at least 6 months out post-infection. So I think is what we're going to see is that the immunity is going to be at least 6 months long and more likely longer.
So 2 questions here. Can someone who got COVID-19 get it again?
Well, yes. So we have seen that in a number of reported cases now, but I think if you were to take the statistics of that, I guess in my head, I don't know the exact numbers. Maybe Fred can help me out, but I'm thinking I can think of 5 cases that I've heard of that happening in all of the cases that we've seen before. So that's a pretty small number. So whether
it's rare.
It's very rare.
So if you got COVID-19, you almost can say, I probably will not get it again, or is that too big of an assumption?
I think that's too big of an assumption. And of the cases we have seen reinfection, I think at least 2 of them that I've heard of have been cases where they've been infected by different strains of the virus. The second more common mutant now is much more virulent. And so that can be a difference too. If you didn't have a very significant infection or high viral load in the beginning, and you didn't make a lot of antibodies and your body's not super ramped up, and then along comes a more virulent strain of it that can reinfect you, that's different. So I think, the air of caution is advised that, just because we don't fully understand all of this yet, but it's clear, or I think it's becoming clear that infection does confer some amount of immunity to this disease.
Okay. And Dr. Jarvis, you wanted to weigh in. Go ahead.
What I wanted him to, again, restate what he said earlier, that the observations that were made about other coronaviruses that have, that occurred many years ago, I think you said it was a 17-year duration, at least in some cases. Restate that data.
Yeah, so in the original SARS outbreak, they had noted immunity and or antibody production to SARS in some patients out to 17 years. Now, I think we've got to expect some sort of Gaussian distribution in terms of patients there, but I think you would expect this type of virus to produce an immune response that will be remembered for a significant amount of time in our bodies.
Well, then and we saw another question here, so we can bring this up right now. Some people that have COVID get affected and are in the hospital, and others just have like a small fever and they're back to normal. And then there's some that seem to have continuing symptoms. So let's take this one at a time. First of all, on the continuing symptoms, if someone could get COVID, I read somewhere that they could have symptoms the rest of their life. Is that too extreme?
So that's actually an observation made about a number of viruses. If you remember what was earlier said, this is a virus that predominantly attacks the respiratory tract. If there is actual damage during the course of the illness to the respiratory tract, even though the infection is resolving, the immune system is responding to it and the virus is being eradicated in the body, there may be damage to the function of the respiratory tract that does not heal very quickly and maybe it may become an enduring effect. People who have chronic effects related to viral bronchitis are well described. I've seen many of them in practice over many years. They continue to have airway problems enduring for many years thereafter, after the severe episode of viral bronchitis. And that I'm using as an analogy to what may be occurring in some of these cases with enduring symptoms, long-standing cough, continuing problems with wheezing and other kinds of respiratory tract problems. It can just simply reflect damage that's going to take the body quite a while, if ever, to heal and improve on.
And I'll add, there are interesting examples or corollaries here with bacterial disease in terms of tuberculosis and Lyme disease, as well as HIV, which is a viral disease where you can have latent reservoirs of these organisms that produce health effects. We have such low levels of the organism in our bodies that they don't cause significantly active disease, perhaps, but they're there in the background in our bodies, that have the potential to produce effects for the rest of our lives.
Okay, Dr. Adler or Governor, do you want to respond to anything?
I'll just say that this is a public policy issue that I think we'll hear more about. The references to people referred to as long haulers. That is to say, people who become ill and then have ongoing chronic disease. Society has not yet been able, we don't know how serious this is or how many it will be, but it's very possible that it could be a social problem we have to deal with and figuring out how to pay for them.
Dr. Adler, did you want to say something?
Yeah, just a couple. I don't know of any evidence that this virus or any coronavirus produces a chronic infection, right? At some point, the virus will be cleared, but the effects may persist for a long time. And just maybe a sort of a question for Dr. Jarvis. I've heard that some of the most severe symptoms and long-term symptoms are more related to blood clots and vascular function, that is blood flow. Do you think that that's convincing, or do you think that it's mostly respiratory?
No, I think that's convincing. There are a number of other body organs, including the clotting mechanisms, the hematologic system, but also the neurological system, that are clearly targets for the inflammatory response that apparently this virus invokes in the human immune system. So they're standby damage, if you will, in these other body systems that can itself become a driving problem of symptoms that last, and again, who knows how long. As Governor Leavitt just said, we're just barely beginning to recognize long haulers, and that's a very general grouping. People simply are in that group because they have enduring symptoms, not because we know exactly what caused it or haven't grouped it by organ systems. It's clear, though, historically, it's clear viruses can do this. Despite the fact that measles is best known for the rash, it is also a cause of encephalitis. And so some small subset of people who get measles have enduring central nervous system problems related to that. Likewise, in very similar fashion, it's going to happen with this virus as well.
Okay. Isn't it safe to be that most people, if they get it, there'll be a certain percent in terms of the number that will have will be requiring hospitalization, but most people will recover and recover reasonably well. I think it's important we not leave people with the sense that they're destined to lifelong symptoms if they happen to contract COVID.
No, that's correct. In fact, most people probably fit in the category of not having any symptoms at all, simply being infected and contagious, and then clearing the virus without becoming ill.
Wow. Okay, let's move on. Next question. Who should be tested and when if no symptoms are evident? Who wants to take that one?
I would say everyone should be tested every week at least. Right? That's what the countries that Governor Leavitt referred to have been effective in. Test, trace, quarantine. That's I think the single best tool we have to control this. And testing is something that we can do for far less expense than having somebody in the hospital.
Okay, but Dr. Adler, when I've said I want a test, they first say, well, you got to have symptoms. Are we past that now? Can we get a test without symptoms?
I don't run the world, so I don't think we can. I don't really know what the policy is, but there's been a push from the state government, at least for students at the U, to get tested weekly with or without symptoms. I think
Okay.
find a way to make that happen for everybody.
And at the state,
yeah, go ahead, Ryan.
at the state level too, I believe it is now practice that if you've had significant exposure, you can get tested even without symptoms, but
Okay.
it's still limited to kind of a known exposure to a COVID positive individual.
Okay, well, let's lead into something here. If we say who should be tested when and no symptoms, hold on just one second. Who should be tested when and no symptoms? What are some basic symptoms of COVID-19 where people say, if I've got these symptoms, I'm most likely have got COVID-19? I have read that taste is one of them. Is that correct?
Yes.
Loss of smell is one of the characteristic symptoms of infection. Yes. Respiratory symptoms like cough and shortness of breath and wheezing would also be included. Fever is also in that group. I do want to say, though, Tom, related to testing people who are not symptomatic, we have been flying blind in the United States without the information, at least of sampling populations who are not symptomatic, to try to find out what percentage of them might be contagious and where those people are. We've been flying blind because this virus, as I just said, is highly likely, much more likely than some viruses, to be associated with an asymptomatic state, a contagious asymptomatic state. We just don't know that pool of people because we haven't had the testing capacity that we needed from the get-go. I think Governor Leavitt was way too modest when he was talking about his efforts as Secretary of Health and Human Services related to pandemic planning. And I'm sure that a major portion of that plan included gearing up properly to be able to test widely and early so that we would know where the virus or whatever the microbe was, where it was and which populations were being affected, and therefore being able to plan appropriately and respond to it very specifically.
Yeah. Now, Governor, I think you wanted to weigh in, didn't you?
No, I'm just going to accept Dr. Jarvis's compliment and let it stand. Thank you.
Okay. All right. Let's go to the next question. Do you think that COVID-19 will ever be eradicated? And if so, when? Ryan, jump in on that one.
Sure. So I don't know, but I think there are some interesting parallels in this. And I think it starts with the fact that these vaccines appear to be 95+% effective. So I think from a standpoint of vaccine efficacy, and eventually if we can deploy it and enough people get vaccinated, right, just like smallpox and measles, we can get to a point where we potentially can eradicate this. The converse of that is that this is an animal disease, and just like the flu, that's an avian disease, right? Probably the only way we could ever get rid of the flu is if we killed every bird on the earth, and we can't do that.
Because I was going to ask you, the flu we still haven't got rid of, and
yeah,
probably
and
never will get rid of.
Yeah. And so one of the things, we can't rule out with this is, like, for example, you've probably heard the stories about all the mink farms and the minks that they're having to put down and stuff. We don't know about how this virus will go back and forth between human and animals and mutate and change its form. So will we ever get rid of it? I'm not sure because of the human animal transmission, but in terms of our now kind of medical ability to potentially deal with it, the answer is we could do that from a vaccination standpoint if it doesn't go back and forth to animals and mutate.
All right, Dr. Adler, did you want to say anything there?
Yeah, I mean, I don't think it's going to be eradicated the way we can eradicate diseases, partly because of the animal reservoirs. But I am somewhat optimistic that it might become more like the other coronaviruses. Like, there's 4 coronaviruses out there. They cause colds. Everyone on this call has probably had all of them multiple times. And it's possible that because we get exposed to them when we're young and less vulnerable, as we've seen with COVID, everybody's going to be at least partially immune for their whole lives. So I'm optimistic that in the long run, the vaccines are really accelerating that process of making us all at least partly immune. And if we're partly immune, the cases might be much less severe. So that's, I don't think
Let's
of it, but I think.
anybody else? Yeah. Okay, let's move on. We want to try to get to May as possible. Will there be an upcoming state of emergency or a quarantine for Utah? We kind of talked about that, Governor. Do you think there will be?
Well, I don't know. I think that Dr. Alder made the point that we're doubling every 3 weeks. Today we had 4,000. Tomorrow, the pattern tends to be that we get the bigger numbers on Wednesday, Thursday, and Friday, or Thursday, Friday, and Saturday, mostly because of the way the testing centers are open. And I don't think that has much to do with the virus stopping. If we saw a doubling again, I mean, we could see between now and Christmas doubling again. And if you do the math, this week we had just under 25,000 new cases. If you said we're going to have 50,000 new cases, the math's pretty simple. About 5% of those will need to be hospitalized. And those numbers simply can't be contained. So it's not inconceivable to me that we would need to do something more than, we may need to put more Swiss cheese together than we are at this point, to go back to my earlier analogy. Candidly, in my view, there's a natural moment for us to do that. And it would be at Christmas time. You don't have to close schools, they're closed. You don't have to do colleges because they're closed. You don't have to ask people not to go not to go to work because to a large degree they're taking vacation. This would be a natural time for us to try to do something to knock this trend down. There tends to be right now an attitude toward not doing that, but I don't think it's going to be easy to predict what things will look like 3 weeks from now if we were to have another doubling.
All right, but let me be the devil's advocate a little bit here, because if you shut down, or we go to a heavy lockdown, what about the economy? What about the effects of the psychological problems, the possible suicides, etc.? Is that not a real thing that has to be considered?
It's a real thing. Anytime you are using any kind of government power to limit activity, you're applying in a ham-handed way a medical countermeasure.
Okay. So Dr. Jarvis, do you believe we should lock down?
Pain medication. I'm saying
sorry.
that if we
Governor, go ahead.
Yeah, if you did, there's a limit to what you can do, because the side effects of that, just like you're saying, are substantial. So there's a counterbalancing that has to be done. But there's a point where if you don't have any room in the hospitals, if you don't have the capacity to care for people, there's a point where action will have to be taken. And we can just all pray we don't get to that point.
Okay, I'm sorry, because you phased out, Mike, and I thought you were done. So now you're back on. Dr. Jarvis, do you agree that we need to lock down?
Well, I agree that people will naturally rise to greater and greater and allow greater and greater restrictions as the death toll rises. And that was what Dr. Alder was saying, will be doubling every 3 weeks. I think that we need to really seriously approach these non-lockdown, but still important interventions that we haven't really fully used. I think we need to, we're finally getting in the last couple of weeks a lot of talk, not just from Governor Herbert and Dr. Dunn, but a variety of other members of the community are coming forward and saying, look, wear your mask. We really still haven't fully seen the benefit of doing that across Utah. Could that possibly finally be something that we all embrace and do? If so, perhaps we won't get to the point where we were just talking about, where we have so many sick people that we just simply can't care for them anymore. I hope that, and I pray that is what happens. But the history of lockdowns and quarantines across hundreds of years of human pandemics has not been one of great unbridled success. I've recently read about the pandemic that occurred in London of the Black Death, the Black Plague, 400 years ago. And people were told to stay in their homes. Now, that didn't turn out to be a very effective means. They didn't understand everything about how that particular pandemic was transmitted. But people refused to comply. They would crawl out the back window of the house and get out. We've got to get on the same page. This is what I was talking about earlier. We need political leadership, and I agree with Governor Leavitt. That needs to involve people who have the proper background, medical and otherwise. But it's got to be people in the business community too, and everybody's saying, look, this is far more important than whether the economy rises or falls, or what the stock market looks like. People's lives are the reason why we have an economy, for Pete's sake. Yeah, let's do what we need to do.
That's true. Dr. Adler, what does the data show? Are we headed for a disaster?
It looks bad at the moment. I'm hoping that Dr. Jarvis is correct and that we can take the measures that we need to take that don't get us to this point. But yeah, I haven't worked out the numbers myself, but another doubling looks like a disaster for the hospitals. And I should say that many of the deaths that occur then are not COVID deaths. There's other people who fail to get care. We've seen that in Italy and New York and other places. If the hospitals fill up, death rates from other things go up too, because we don't have the available beds and health professionals.
All right, let's move on. Next question. How effective do you anticipate the 2-week stay-home actions to be? How high could our daily case counts go if we don't intervene? So we've kind of answered that. Dr. Adler, really quickly, do you want to make any comment there?
Yeah, I try not to anticipate the future, particularly with human behavior is concerned. I mean, the numbers have been so frightening. I do think people are going to be more responsive in the next few weeks. I don't know. I mean, I'm not going to try to predict the future, but I really hope we don't see another doubling.
Okay, next question. Why do some older people get light cases and some the same age are much worse? Is that related to our immune systems? Ryan, you want to step in on that one?
Sure, and I'll let Dr. Jarvis comment on this as well, but I think it goes back, and the reason I say that is it goes back to his point that him and Dr. Adler were talking about as well. In terms of this virus appears to attack so many systems that it can be devastating. It depends, if you have any weak link, whether it's your, your blood clotting cascade, whether it's in your lungs, your kidney, your heart, inflammation, depending on how the virus attacks and where it causes the greatest harm in terms of inflammation, can just affect different people differently. And so I wish we knew kind of the rules for this, but we haven't figured that out yet. And in terms of the question of, is it our immune systems? Yes, it's our immune systems, not only in terms of how well they may handle a response in these different target organs and target systems, but also just how active they get overall, right? So you've heard a lot about the cytokine storm and the interleukin dependent inflammation that's fostered by or mustered as a response to the virus. And yes, in some people that just goes crazy. And again, depending on the individual, depending on which target organs or system that's involved, we can have very, very different responses.
Dr. Jarvis, you were mentioned. Do you want to weigh in?
Sorry.
Yes, the simplest way of thinking about this is that there are commonly differences in patterns of disease between men and women. And that's easy for most people to understand. Everybody knows that men have an XY chromosome pair, women have an XX. The Y chromosome being shorter doesn't have a second gene for a number of things that are found on the X chromosome. So if there's an inherited, less functional, say, immune system gene on the single X chromosome that a male has, and there isn't a matching one that could improve its function because the Y chromosome doesn't contain that, men will be more likely to have that somewhat less functional, whatever it is, in the immune system. Whereas women have the advantage of having a second one of those genes, and therefore may be more likely to be able to actually express something that's more functional and better able to handle this new and different exposure, which is this novel coronavirus. So it has been noticed that men and women their pattern of disease is a little bit different. Men tend to be more likely to have the higher morbidity, mortality. Women tend to be the ones that are more likely to perhaps fit into the long hauler category. It's early, and I don't want anyone to quote me on that, but that's an example, a simplistic one, of how it is different for different people. And we just simply don't know enough about this. The human organism is, after all, a very complex thing, and those 40 some odd chromosome pairs, that's a lot of information. So end of my response.
All right, thank you. Let's go to the next question. What should Utahns do to prepare for what will likely be a very difficult winter? I think we talked about some of this, but
Wear your mask.
who wants to weigh in? Yeah. We definitely got to wear masks. So that's evident. Anybody else want to weigh in on what we got to do?
So I'd say wear a mask, number one. Number two, don't go to indoor spaces with people from outside of your household. Don't do that. Stay in your household, indoors. We've already talked a little bit about, how to keep the indoor environment optimal, so I won't go through that. And then, of course, socially distance when you have to go to an open place like a grocery store, and wear your mask. Wear the mask. That ought to be the first 10 things that we say about this.
Okay. Kevin, I wanted to ask you one thing, though, really quickly. Why are people, from your experience that you've been working here, resistant to masks? Is it just they don't like to be interrupted with their freedoms? So why just people won't put on a mask? It doesn't seem to be that big of a deal. They're now available. I just don't understand why people don't want to do it. Can you give us some insight on that?
Well, I wear my mask, like that, be clear. But I do think that to some people it's become a symbol of an ideology that offends them. And to me, that's not a logical thing. But it has become, and I think to some extent it has been politicized as a symbol. And once that occurs, then it ceases to be done on a logical basis. It's done on an ideologic basis. But I think, as has been described here tonight, masks aren't perfect, but they help a lot. And they're among the most reliable things that we have, but they do need to be used broadly. We've just finished an election. And it's been my observation that the world sort of breaks itself into two parties, the me party and the we party. The me party is worried about the mask on themselves. The we party is recognizing that we all have to do this together. There's a place for individual liberty. There's a place for us to cooperate. This has got to be a blend and a balance.
Ryan, did you want to say something? I think you were nodding your head, or?
Amen. I think I was.
Yeah, amen to that. Okay, Dr. Adler, you agree?
I totally agree. That was a beautiful statement. I did want to say one thing about preparing for the winter. We focused on the pandemic, but you referred earlier to some of the other challenges we face, like psychological challenges, right? We should also, stay in touch with our families as much as we can. We should do things outdoors, to not enter indoor spaces, but do things outdoors to maintain our psychological health and as a way to see other people. And I would recommend that people spend some time at home learning mathematics, but that's just my own.
All right, let's go to the next
Can I
question.
just say one other thing about this?
Yeah, go ahead, Dr.
Exercise.
I just think it's vitally important that we keep in mind, this discussion has pointed out a lot of hard things, but this is going to end. And a year from now, we'll be in a much different situation. The very good news about vaccines is exactly that, great news. We can see the beginning of the end right now, but we have the darkest and most dangerous 3 or 4 months in front of us right now. We don't have to endure this forever. We just need to do it for 3 or 4 months. And that's a long time, and it feels inconvenient. And all of us feel like this is an awful situation, but we can get through it. And when we do, things will start getting better. And I believe a year from now, life is going to be much more as we remember it 8 months ago than it will be as it is today.
Okay, we're running out of time. Let's try to get as many questions here as we possibly can before we end. What is the expected efficacy of COVID-19 immunization? Is there information about long-term negative effects of an immunization? Really quickly, Ryan.
Yeah.
So
we've discussed this. We've got excellent efficacy, and kind of similar to all vaccines. Although these are new vaccines, the way in which they ultimately work is similar to other vaccines, and so the long-term negative effects should be minimal, but we can't know that until we have a long-term vaccine.
All right, next question. Next question. Can you address the long-term effects of this disease on children? Who wants to quickly answer that?
There has been a description of multi-system disease affecting children principally. And again, it's way early to be discussing long-term consequences of that. These are very serious illnesses, these multi-system inflammatory conditions that affect children. Life-threatening, which is unusual. Children generally survive and have relatively milder cases. That's all I can say right now. I think a lot more data is going to come in. There are multi-center studies going on collecting cases so that they can learn a lot more about this.
Okay, next question. While Utah has had a very high percentage of cases per million people, why has the death rate been relatively low compared with other states? Governor?
I don't know the answer to that. Yes, I don't know the answer to that. I'm not even.
Dr. Adler, is that one for you?
2 main reasons. The population is younger, right? We're the youngest state in the country by a fair margin, and the population is healthier, right? People don't smoke as much and we're very outdoorsy. So I think those explain a lot of the difference.
Okay, one last question. Go ahead, Cassie. What do the panelists see as the key logistical challenges for possible vaccine distribution in Utah? Ryan?
So logistical challenges, I think the governor would speak best to this, but I think there's probably going to be a pretty good job in rolling this out. I think the bigger question is what we going back to what we had discussed is, can we ensure that we are all personally responsible to maintain our community safety while the vaccine is being rolled out? So for example, if I think about teachers going back to school, I would love for teachers to get vaccines before we start putting kids back in schools. And that can happen in the near future, but we've got to keep safe until that can happen. So I think the biggest logistical challenge is making sure we all stay as safe as possible until the vaccine makes it to a lot of the high-risk populations.
Okay, one more. Let's get another question in here. What is the state doing to alleviate the financial burden put on students to upgrade their technology for virtual classrooms? Who wants to really take that? Governor, it's,
Well, I'm not current on this point. I will say that the access to broadband internet access is pretty high in our state by comparison to other states. And I'm not following what the legislature's done there or what their plans are.
okay. All right, I guess we can take one more. Go ahead, Cassie. Given a certain mutation rate, do you anticipate that people will get revaccinated every year just like the flu? And I think you answered that, right, Brian?
Yeah, so again, it's too early to tell, but I think one of the good things we have going for us is that, as Dr. Adler mentioned, this virus does mutate relatively slowly compared to other viruses, half as fast as the flu, 4 times slower than HIV. So that's good. And the major mutation that we are seeing, this what they call the D614G mutation, doesn't affect the protein that we're raising antibodies to or our immune system's recognizing. So for example, that mutation that makes the virus more virulent, our vaccine should still be effective against that mutant of the virus. So that bodes very well for continued efficacy of the vaccine. Now we just have to see how long the immune response lasts. And as we've talked about, we may be in good shape for that as well. So hopefully
Okay.
every year.
Okay, I want to thank everybody. We just have a few minutes left. So what I would like to do is have each of you just give a quick summary statement. We'll start with Dr. Jarvis and then go to Dr. Adler and then Governor Leavitt and then Ryan. So Dr. Jarvis, a summary statement for all the people that are listening here. What do you want to tell them?
This episode in our lives is a once in a lifetime event. I think it will show who we really are, both personally and in our families, whether we can rise up and care for our families and love them enough to do the right thing and help them, and also in our communities. Can we come together? Can we do big things still? This is a once in a lifetime chance to show our mettle.
Thank you very much. Dr. Adler, go ahead.
Yeah, I want to mention one thing that we haven't really discussed, which is how this virus has exposed many inequities in our society, both racial and socioeconomic. And I feel like we should use this as an opportunity, like Dr. Jarvis just said, to come together, not only to fight this virus, but to fight those inequities that it has exposed.
Thank you. Governor?
I'll just say again, this will end. We'll work our way through it, a sense of control in our own life, do the things that will help us avoid contact with the virus. If it happens, we're lucky to live in a great community where medical care is available. And I remain optimistic that we can do it here as well as anywhere in the world.
Thank you. And then Ryan?
Yeah, the cavalry's coming. Keep your masks on until it comes. We can all help each other out. And I have I'm proud to be a scientist, but I'm also a proud father of 3 school-age children. And I think, to Fred's point, the inequities that we see, not only socioeconomically, but in terms of education and everything else that's happening right now, we're going to have a lot of challenges ahead of us after the immediate medical pandemic is done here, which will end. And we have to come together as a community to address those and build back better.
All right. Well, I want to thank all the panelists. You guys have been excellent. This has been so fascinating. I'm sure everybody who's been listening has been just educated and got some really good facts. Let me remind everybody that this will be on the YouTube side of the College of Science, and you'll be able to get that link. It will be emailed to you if you want to hear that. If there's some people that want to make some comments, they're happy to email those as well. We have been really fortunate to be able to have these panelists take their time. And so I want to thank Dr. Jarvis for all his time, and Dr. Adler and the governor, and Ryan. We appreciate so much your knowledge, your expertise, and your service to the community. And I want to reemphasize that one, nobody's immune. Anybody can get this. Number two, it's real. The cases are doubling every time. Number three, we've got to put on a mask and do preventative measures because we don't have a vaccine. And four, even though we get a vaccine, we still got to keep on preventative measures if we're truly going to eradicate this. And then to illustrate Dr. Jarvis' points, number five, this is going to test our mettle. And I have confidence in us that we will do this and we'll do it well, and that we will get through this. And it's certainly been a challenge because I can't think of anything that's affected every single human being. I mean, just your friends all of a sudden call and say, hey, I've got COVID. It's just amazing how this has just infiltrated every aspect of our life. Thank you, everybody. I appreciate everybody's time and attention. And hopefully we're going to be able to try to do this again. We'd like to do these every quarter, not necessarily on COVID all the time, but our goal is to try to, with intuitive funding, to try to do community service by doing these type of webinars. And of course, we hope one day we can all meet together so we can get to know each other better and have a good relationship. Thanks you very much and good evening.
Thank you for the amazing metaphors, Governor Leavitt. I'll be using those in meetings to come.
I hope they're helpful. I'm sure I borrowed them from someone.
Good to see you all. Thanks. And I enjoyed being with you.
Yeah. Thanks. This really was a good panel.
Yes. Thanks, Tom.
Yeah. Thank you, Tom.